All right, so spine trauma and the aging. So, as Jens has said, and as other speakers have touched on, it's increasingly a problem, and we see an increasingly aged population with different parameters of their injuries and different things that we need to think about to successfully treat them. No disclosures for me. This was a patient who I've treated over the last couple of weeks. So when I was putting the talk together, and sort of a testament to how common it is, these images are from about 2 weeks ago, and so has just been treated. But a 90-year-old male who fell down the stairs and sustained multiple injuries: a small right-sided pneumothorax, multiple rib fractures, pulmonary contusion, small left intraventricular hemorrhage, and a cervical spine fracture. Doesn't go to the doctor regularly, hasn't had a checkup in years, but his granddaughter is a fifth-year resident at our institution in general surgery. So here's his fracture. And he walked into his primary care doctor and then was sent into the hospital with this, and was evaluated and told he needed surgery, told he needed a chest tube, and refused both. Said, "I'm 90 years old. I don't really want anything done." And so we spoke with him some more and said, "This is you're 90, but you're healthy, you're functional. If you don't have something done, you very likely will be quadriplegic and not do well with this injury." So kept him at spine precautions overnight. He was spoken with his family, and as we talked about, the broader discussion with the family was part of this. And the next day, took him to, actually initially refused surgery still the next morning, and then by noon had changed his mind, and so about 2 o'clock in the afternoon underwent this surgery. So uneventful surgery, really. About 3 hours or so. Reasonable blood loss, I thought. Watched very closely because still didn't have a chest tube and had an apical pneumothorax. Hemoglobin started at 9.9, transfused intraoperatively a couple units. Really, probably, maybe didn't need it, but just to optimize them. Ending hemoglobin was 10.7, so actually went up because of the transfusion, and that's what we achieved. But I think the interesting, one of the interesting things, and one of the themes of the talk, is this is what happened intraoperatively. Is started out immediately pre-op with a pH of 7.39 and a PCO2 of 4 and a base deficit of 0. But intraoperatively, still about the same, maybe base deficit worsening a little bit. Immediately post-op, you can see his pH is 7.19 and his base deficit is minus 5.2, and he's retaining a PCO2, maybe related to pneumothorax, maybe related to cardiopulmonary reserve that in a 90-year-old, right? And then had aggressive resuscitation in the ICU, and you can see started improving 8 hours post-op, and part of the ICU care included BiPAP and respiratory support. And this is the last blood gas he got, because after this he did fine. From this standpoint. Eventually, a couple days later, his pneumothorax had not resolved, and he got a chest tube. And then about 3 days after that was taken out, and he walked out of the hospital 2-3 days ago and doing great. Okay, so so that was a treatment result. And although certainly his concerns and our concerns are and partly played out is how is a 90-year-old going to respond to surgery, and how do they respond differently than a 60-year-old or 40-year-old or 20-year-old. So treatment decisions, non-surgical versus surgical. When do you operate on somebody? When are you more aggressive or less aggressive? And sometimes, and a timing of surgery, when is earlier surgery more important than delayed surgery? And how do you make these decisions? And I think one of the, what I would say, to borrow from one of my teachers in public health, is it depends. He would constantly say it depends, and in this case it depends. These things are things that you have to individualize, knowing what the different decision points are and how they affect, or how you think they might affect the outcome. And then, of course, there's technical considerations, and we've discussed some of them. Dr. Herbert discussed some of them in the cervical spine, and I would say that we'll get into that a little later in the talk. But a lot of the things that we talked about, I did in this surgery to try to address some of the technical concerns with doing a surgery in a 90-year-old with decreased fixation strength and somebody who's autofused with this multiple levels above and below. So trauma in the elderly, what's the most common mechanism? Falls. It's low energy falls for you and I, but that energy translates into a more significant injury for an older patient. And the second most common is motor pedestrian collisions. So less energy causes greater injury in the elderly. Complications have a greater impact on outcome, and probably most importantly from a broader perspective of treatment is that less functional capacity, particularly cardiopulmonary, limits the ability of them to respond to injury and to complications. So again, that makes a difference in timing and makes a difference sometimes in whether you should perform surgery at all. For instance, Dr. Daly's talk on odontoid fractures. That factors into what you do, as you're thinking on, where they are in that spectrum of physiology. So what are the factors that affect outcome, and mortality being the ultimate outcome, right? Increasing age is directly proportional with increased mortality. Makes sense, right? Pre-existing conditions are predictive of mortality, but not so much in older patients. Age is actually the overriding factor. And so one of the questions about this was what's the most important determinant? Is it chronological age? This was Jens's question. Is it chronological age, or is it physiologic age? And it's really the physiological cardiopulmonary sequelae of having advanced age. So it's really physiologic age, I think. We'll get into that more. ISS is not as correlative with mortality as in younger patients. And the GCS, less than age predictive of mortality in elderly patients. But if you start looking at mortality from injury in the elderly, and this paper from Shabat, what you see here is that as your ISS goes up, within ISS groups, there is statistically significant differences in mortality between the oldest, compared to elderly, compared to younger patients within those groups of different ISS, right? So if you, but if you break it down by physiology and look at the simplified acute physiology score, within those groups of physiology, there's not statistical significant differences. Okay, so it's really physiology is the important determining thing. It's not so much age, ISS, it really is physiology. So those are things that we're stuck with, right? They come in, they're at a certain age, they have a certain physiology, at least a presentation that they're going to have. But then there's treatment decisions that affect that as well. And so what's the effects of under-resuscitation? So a different paper by Davis, Journal of Trauma, 1998. And what you can see is if they're under-resuscitated, so back to the concept of early appropriate care from my previous talk, so their base deficits here, if you look at normal base deficit to mild to moderate to severe, the mortality rate goes up for all groups, but it's much more pronounced in older patients, in elderly patients. So again, the physiology plays an even greater role in elderly patients with how they're going to do. So surgical timing, so this was our study. This is a study I did back when I was a fellow, published it a couple years later. Over 1,000 patients, and we looked at thoracic and lumbar spine fracture treated with stabilization. And these are what we found to be significant factors. And one of the things I would say is that, predictive respiratory failure, these are presenting things, age or greater than 35 years. So even younger patients have physiological determinants of outcome. It isn't necessarily people over 60 or 70 or 80. So there are, so that even depends at younger ages. But those are all things at presentation. And then here's the thing that we could change, right, is when did they have surgery? And we found that 48 hours or 2 days was determinant of when they had an increased respiratory failure rate. And this is from our paper, but I changed the order of the analysis, and it's a predictive algorithm for the relative risk of respiratory failure if you did surgery early versus later, less than 2 days or greater than 2 days. And what I did was, if you look at each group, the age, so the top group is they didn't have any predictive factors or presentation of GCS, age, or blunt chest injury. And then if you look at, now their age is greater than 35 years, their predicted probability of respiratory failure went up 2.3 times relative to none, just based on age. And if you go to the second group of 2, it went up 7.1 to 3.4, just based on age at less than 2 days after injury. And if you look at greater than 2 days, it also goes up starting at a greater baseline. So timing of surgery puts them at a higher risk if you delay, but also age, and so they're both important. And then the last point, technical considerations, and we've touched about a bunch of these things before, but to summarize them, this is that same patient, the 90-year-old, and so what did I do in this patient that I might have done differently in a 40-year-old or a 25-year-old? Well, levels of fixation, right? So in a 40-year-old, 25-year-old, I might go 2 above and 2 below. In an older patient with dish, especially, I would 3 above and 3 below. I'll use crosslinks every time. Don't always use crosslinks. I'll do bicortical. I didn't put this in here, but bicortical fixation. This, like we talked about before, and I think that's very important. Sometimes we'll augment with bone cement, and I think Dr. France will talk about that. And then going back, so that was one of my latest patients, and this was my very first patient in South Carolina 12 years ago when I first moved down there. A very first patient with so 70-year-old had a rollover motor vehicle collision. They took her out of her car, and she was upside down in the car and came in with this fracture. And we initially treated her in a brace, and she fell into more kyphosis. And so this is what we did. And augmented the screws with polymethylmethacrylate, augmented the fracture with polymethylmethacrylate. And there's 3 months post-op. And I actually saw her at intervals for about 7-8 years until she passed from other causes, and did fine the whole time from this. So, thank you.